Hey guys, welcome to my channel Tooth Bunny. Today I'm going to be talking about residual resorption. Now this is a topic from prosthodontics and I'm going to be covering it under these 6 topics so that it's easy to remember. Now if you're attempting a theory exam, it will be very easy for you to remember everything under these 6 headings. And if you are somebody preparing for your competitive exams, I think all the information that can come up in your MCQs will also be covered. So I hope you enjoy the video. Now starting off, these are the 6 topics that I'm going to be covering it under. Now starting with the definition and the introduction. Talking about the definition, this is your GPT 9 definition. Now residual resorption basically means the diminishing quality and quantity, both quality and quantity of the residual ridge after teeth are extracted. This means that after we extract the teeth, there will be reduced quality and quantity of the residual ridge, that is the bone. Now, what can be the reasons for this diminishing quality? These are our 3 reasons. Firstly, there's a decreased efficiency of osteoblasts. Now, as you know that osteoblasts are actually the bone forming cells. Now, if their efficiency decreases, obviously the bone deposition will also decrease, and so will the quality and quantity. Next, we have estrogen production. This is also decreased. Now, estrogen is again another factor which helps in bone deposition. Now, the similar logic, if it is reduced, so the quality and quantity again get reduced. Next, the calcium absorption from intestine is also reduced. Now, obviously, the role of calcium is very eminent in the bone formation. So these are our 3 basic reasons why the quality and quantity of bone decrease with age. Now this is a very rather common occurrence. So it is going to happen in anyone and everyone eventually with age. One thing that we can remember is that RRR is more prominent in females than males. Okay? Next thing that we come on to is the classification. Now classification, an easy way to remember is, firstly it was given by Atwood. Now you see ATWOOD, 6 characters. Atwood gave this classification. It was basically the progression of RRR. This classification was used to determine the progression of RRR. Now we have 6 orders. You remember from the number of characters. Now there are 6 orders. These are the 6 orders. First is pre-extraction. Now conversely, I'd like for you to see in the picture below here. Now this is pre-extraction. Now the tooth is present and there is an only minimal bone loss. Class 1. Actually it is in orders. So order 1 is basically it is dentate, which means pre-extraction, right? Next we come on to the order 2. This is post-extraction. Post-extraction, here you can see this is the space left after extraction. Now this is immediately post-extraction, the second one, the second order. This is how it looks. Third order is high and well-rounded. Now it has started to heal over here, right? The bone's coming back. So well-rounded, you can see here it's well-rounded. In adequate height and width. Now this is immediately after extraction. Now it becomes high and well-rounded. Next we have order 4, which is knife-edged. Now eventually this is going to become knife-edged. Now you see here there's adequate in height. The height is same. You see? It's the width that is compromised. Now here everything was fine. It was well-rounded. The height was fine. Here the width has reduced. Okay? So this is 3rd order and this is 4th order. This is knife-edged. This is high and well-rounded. Next we come to the 5th one, which is low and well-rounded. Now the height has reduced and so has the width. Now both are inadequate, right? But you can see that it is well-rounded, just like here. Not, I won't say it is as good as this, but it is well-rounded. It's a rather flatter form. You see, this is so round, and this is a rather flatter form. So low and well-rounded, and here you see it is a flat ridge form and inadequate in both height and width, right? Last we come to the sixth order, which is depressed. Now this is depressed, you see, and there's also some basilar loss. Okay, so I hope the 6 orders of classification are clear. Next, I come on to the factors which are going to affect your bone resorption. Now, a way to remember them is MAM. RRR and MAM. The first M is for mechanical. Now this means that if there is disuse atrophy, basically if a patient decides to totally go on to a liquid diet, so they're not using, so that is disuse. So because of the disuse atrophy, the bone will start to resorb. Next, suppose the patient has actually started wearing dentures. Now here, due to the increased force on the ridges, eventually there will be resorption. So both are going to cause resorption. Next, we come on to anatomical reasons. Now, anatomical reasons, which I'm going to discuss just after this, is the pattern, how the bone is resorbing. Now, the pattern differs in both maxilla and mandible, and as a general rule, there is more resorption in mandible than maxilla. Last is the metabolic factor, which we sort of discussed before. Now, metabolic factors, there will be resorbing factors and forming. There will be resorbing factors and there will be forming factors. The resorbing factors are majorly the periodontal disease causing factors and heparin, okay? And the bone forming factors, like we did, was estrogen, thyroxine, growth hormone, calcium, vitamin D, all of these. And as you know, with age, all of these are going to decrease. So now that the forming factors are becoming less dominant than the resorbing factors, so there will be an eventual resorption. So the final result is going to be resorption, right? Next thing, we come to the resorption patterns. Now this is maxilla and this is mandible. Now here you can see that resorption in maxilla is going to occur like this and this. So labially and buccally. Now because it is in these directions, like you can see with the arrows marked. Another important thing before that, the red line that you see is the center. So relative to this, we are going to discuss how the resorption is occurring. So this buccally and labially in maxilla, it is going to reduce. Now this is eventually going to cause a decrease in arch size, right? You can imagine if it is going to resorb like this, so it will eventually become smaller. And in 1 year, on an average, 2 to 3 mm loss is seen. Okay? Coming to mandible, again, this is our axis or the general center which we are going to consider. Now here, anteriorly, you're going to see that the resorption is going to occur labially, like this. And posteriorly, it is going to occur lingually, this way. So if it is going to go in this direction and in this direction, eventually it will become larger, right? If originally it was here, like this, here it is decreasing, so it goes in this direction, and then from here it is going in this direction, so eventually it will become this. So there will be a widening of the arch. And like I told you, as a general rule, there's going to be more resorption in mandible. So 4 to 5 mm in 1 year. So these are the resorption patterns. Now that resorption has occurred, what are the consequences that are going to happen because of this? First, there is an apparent loss of sulcus depth. Now we know what is a sulcus. See on the screen, I think I'll discuss the consequences and management together so it's easier to understand. So because there is a sulcus depth, what can we do to manage it? We're going to do vestibuloplasty. Now this I'm going to discuss in a detailed video which will be related to oral surgery. I'll discuss this there. So to compensate for the sulcus depth, we do vestibuloplasty. Next, because the bone level is coming down, so suppose a muscle is attaching here, this level. So if the muscle attachment is here, it was over here, suppose, right? I am considering this point. Now if the bone level comes down to this, so this is going to be, the muscle attachment will become closer to the crest of the ridge. Next, there will be a loss of vertical dimension. This again is a topic of prostho which I'm going to discuss in detail. What is vertical dimension? Now because the general height we discussed, height is going to decrease. Now if this much height was for maxilla and this much was occupied by mandibular ridge, this was my total vertical dimension. Now eventually this much portion has gone away. So it is this and this. So when I bring them closer, right? If I bring them closer, these new heights now, my VD will become less. Next, the mental foramen is going to lie near the upper border of mandible. So if it was here, the mental foramen didn't move, right? This was still here. Initially it was in the middle. As and when the level started decreasing, it apparently came near the upper border of mandible. Next, there will be a flattening of the vault of palate. If this is my palate, the palate is defined by, the extremities will be, if this is my ridge, so it is defined by this. Now eventually if the height decreases, it comes to about this. This is remaining same, but now this is meeting this here, the extremities are meeting here. So the general height, this has decreased. So initially which was something like this will now become flatter, it will be this. And flattening of vault will decrease for the air retention and stability. And lastly, this, I think you can remember this right now just like this. Eventually I think it will make more sense. There will be a pseudo class 3. Now why will there be a pseudo class 3? I will mention the answer in the description, but I would love for you guys to answer in the comments. It is hidden in this video. The answer is in this video itself. Why do you think there will be a pseudo class 3 ridge relation? Now because, coming back to the management, all these things that I did, that there will be a loss of vertical dimension, mental foramen position is changing, there is flattening of vault. This means that constantly the denture is going to become loose, or there's going to be some kind of complaint by the patient. And that is why, to combat all this, there be a continual management. So I'm going to do relining and rebasing very often. Vestibuloplasty I discussed, related to the sulcus depth. Then I come to overdentures. Now this is also a detailed topic, but in overdentures you basically retain the tooth. You prepare the tooth, there's a coping, and then you build the denture over it. So you use this. So you retain tooth. When you retain tooth, the proprioception is also retained. We know that the bone resorption is related to tooth in the socket. If there is a tooth in the socket, there is not going to be bone resorption. So here in overdentures, what we are doing is we are maintaining this tooth in the socket, and thus no bone resorption is occurring. Last is, we can give osteointegrated implants. That's all for this video. I hope it was helpful. If you would like to access the PDF files of the notes that I just used, you can head on to the link in the description. You can also find a direct link on my Instagram. Thank you so much for joining. I'll see you with a new video next week.